In this video, we're going to cover an overview of transdermal drug delivery systems, where we'll learn what transdermals are, their advantages and disadvantages, the precautions we need to consider when using patches, what the basic composition of a transdermal patch is, and finally, the different designs of these patches. Beginning with the definition, transdermal drug delivery systems deliver a specific dose of the active constituent through the skin into the systemic circulation. The most common dosage form for transdermal drug delivery systems are patches, as we can see in this diagram here. So we can establish from what we just said now that the route of administration is healthy, intact skin. The target site is an internal organ reached by the bloodstream. The drug will exert a systemic effect, and the dosage form is a patch. You can think of patches as medicated plasters. They only hold the drug, but once applied to the skin, the drug from the patch will be absorbed through the layers of the skin in order of the stratum corneum, epidermis, and dermis, to ultimately reach the dermal microcirculation, as we can see here, where it will then be carried to the target site. When choosing the most suitable dosage form to formulate our drug preparation, we need to weigh in the benefits and the drawbacks. But relative to other dosage forms, transdermal drug delivery systems boast a wide range of advantages. First, gastrointestinal drug absorption difficulties are avoided, as the drug isn't directly exposed to gastric acid, for example, and broken down, nor is it affected by any pH changes that occur in the gastrointestinal transit. We can also use it if our patient is vomiting, has diarrhea or difficulty swallowing oral medications, or is comatose. First pass metabolism by the liver is avoided, meaning that the highest concentration of drug reaches the target site, which is ideal. Any risks and inconveniences brought about by using parenterals is also avoided. For example, if the patient is allergic to a certain type of substance and that substance is injected into them, adverse reactions will be seen in a matter of minutes and will be fatal if not treated in due time. On the other hand, if the patch contains a substance that the patient is allergic to, it can easily be removed, hence terminating the drug's effects. Patches extend the activity of drugs with short half-lives. They have fewer side effects than oral medications, supplements, and injections. They increase patient compliance because they are easy and painless to use, and they are also non-invasive. And finally, they reduce healthcare costs. Their disadvantages, though, are that high molecular weight drugs and hydrophilic drugs are not well absorbed by the skin. They are unsuitable for formulation of drugs which cause local irritation or sensitize the skin. The patch itself might not adhere well to all types of skin. For example, what if our patient has hairy skin? What if they sweat a lot? All of these are factors which deem transdermal drug delivery systems unsuitable. And finally, the drug must be potent in small doses, since the skin's layers limit the amount of drug that can be absorbed. Right. When we're handling transdermal patches, there are some things we need to consider to allow for proper application and usage of the patch to give the desirable therapeutic effect. The designated site of application must be clean, dry, intact, and hairless. Likewise, patches should not be applied to oily, irritated, infected, cut, or abraded skin. As you might have already noticed from previous diagrams and from this diagram right here, we can apply patches in a variety of areas on the skin, but there are some common sites of application for specific active constituents. Nitroglycerine patches are applied to the chest, estradiol to the abdomen, scopolamine to the post-auricular region, which means behind the ear, and nicotine to the upper outer arm. The patch should be removed from its protective package, and only one patch should be applied at a time. It should be worn for the specified amount of time required for the dose to exert its therapeutic effect, after which it is removed and a fresh patch is reapplied. If irritation occurs upon application to the skin, then the patient should seek a reevaluation. Now that we've finished talking about the overview, we're going to begin talking about the basic composition of transdermal patches one by one. But before we get into the details, I want you to note that depending on the type of patch, some components that we see right in front of us right now might not be included in the final patch. And that all has to do with the functionality of the patch itself. You'll understand what I'm saying in a couple of minutes. Right. There are 5 basic components. The first one being the backing layer. The backing layer is the outermost layer of the patch. It's the first layer that we see when we unravel the packaging of the patch. Its role is to provide support and protect the patch from the external environment. For example, it protects against moisture and contaminants. It must be highly flexible in order to allow for ease of application, and it is made of a material that is impermeable to the drug and other excipients in order to prevent their loss from the patch, such as polyester, polyethylene, and polyvinyl chloride. The next layer is the drug. It's basically the layer where the drug is contained, and depending on the type of transdermal drug delivery system, the drug can be contained in either a polymer matrix or in a liquid or gel reservoir. The semi-permeable membrane. This is the rate-controlling membrane. It's not present in all patches. It's present in the reservoir transdermal drug delivery system, and it controls the rate of drug release from the reservoir to the stratum corneum of the skin. As such, it ensures controlled and consistent delivery of the therapeutic drug dose. The adhesive. The adhesive is a very, very important component of the patch, as it ensures the patch sticks to the skin securely. This is the sticky part of the patch. Without it, the patch would be deemed dysfunctional, and as such, it is such a crucial component of all transdermal drug delivery systems. In some designs, the drug can be incorporated into the adhesive, as we will later see. And because the adhesive is such an important component, it must meet some requirements. It must be non-irritating and non-allergenic. It must stick to the skin for the patch's lifetime and be compatible with the drug and other excipients, and it should easily and painlessly be removed without leaving adhesive residue on the skin surface. The last layer is the release liner, which is the layer that is removed to allow the patch to adhere to the skin surface. It's a non-medical layer, but it's very important in protecting the patch, and it should be removed before application to the skin. Since it's also a very important component, it must meet requirements. Upon application, it must easily peel away from the adhesive, but when it's not used, it must firmly hold onto the adhesive, and it is usually occlusive to prevent loss of any volatile components in the patch, such as ethanol. Now that we've finished talking about the 5 basic components, we're going to talk about the design of transdermal drug delivery systems. When we're designing patches, we can add or remove certain components and tailor it to our needs depending on which drug we incorporate into the patch and what we want its duration of action to be. There are many types of transdermal drug delivery systems, the 3 most common being the drug-in-adhesive system, the matrix system, and the reservoir system. Let's talk about the first one, drug-in-adhesive system. This patch consists of 3 components: the backing layer, the drug, and the release liner. But notice here that the drug is incorporated into the adhesive. That means that when this patch is applied to the skin, the drug will diffuse from the adhesive directly into the skin. It is the simplest and most common transdermal drug delivery system, since there are minimal layers that the drug has to diffuse through to reach the skin. Anything that we can do as pharmacists to facilitate the patient's therapy process is a huge win. So the fact that this patch is thinner and more flexible than other patch designs means that patient compliance will be increased, therefore giving the full therapeutic effect and ultimately improving the patient's quality of life. Next up is the matrix system, also known as the monolithic system. This patch consists of 4 components: the backing layer, the drug, the adhesive, and the release liner. In this patch, the adhesive and the drug are in 2 separate layers, and instead, the drug is dispersed or dissolved in a polymer matrix. The drug would have to diffuse from the matrix to the adhesive layer to then be able to reach the skin. And in this way, we can establish that the polymer matrix is the component which controls the rate of drug release from the patch since the drug is incorporated there. An example of patches which uses this system is the Nitrogure patch, which supplies nitroglycerin within a span of 24 hours to angina patients to prevent them from suffering from chest pain. It is applied to the shoulders or the chest area. The last type of system that we're going to cover is the reservoir system, also known as the membrane-controlled system. It consists of all the components we talked about initially, and what differentiates this type of patch from the other patches is 2 things. First, it contains a semi-permeable membrane, which plays the role of ensuring controlled release of the drug from the patch to the skin over an extended period of time. Second, the drug is dissolved in a liquid, or more commonly, a gel reservoir. The semi-permeable membrane separates the reservoir from the adhesive layer, and as such, we can establish that the semi-permeable membrane here controls the rate of drug release from the patch. An example of patches which uses this system is scopolamine, which is named after and supplies the active constituent scopolamine to remedy motion sickness, nausea, and vomiting. It is placed post-auricular and exerts its effect for 3 days before being replaced by a new patch. Something important we can note here is that the best site of application for transdermal patches is post-auricular, as the blood supply there is more dense and the skin is relatively thinner, hence allowing the active constituent to exert its therapeutic effect faster. To conclude this video, when we come to compare the different types of patches, we will realize that all patches contain 4 basic components: the backing layer, the layer which carries the drug, the adhesive, and the release liner. The main difference between the patches is where the drug is incorporated, whether it may be within the adhesive, in a polymer matrix, or in a liquid or gel reservoir. The semi-permeable membrane is only found in the reservoir system, which gives this system the advantage of delivering the drug in a controlled manner through the skin over an extended period of time. And that will be all for this video.